Good afternoon, dear colleagues. I would like to thank organizers for opportunity to present a commentary on the impact of COVID passports in Lithuania, published in Journal of Infection. I am a pharmacologist, so my field is the effects of medicinal products on the body. The subject of my scientific research is adverse reactions to medicinal products. Earlier, I worked as Deputy Director at State Medicines Agency of Lithuania and was responsible for marketing authorization, supervision of clinical trials, and pharmacovigilance. Also, I was a member of various committees at the European Council and the European Commission. The background of our paper. Lithuanian scientists who were involved in establishing governmental COVID policy published a paper speculating that COVID passports prevented approximately 330 to 720 deaths in Lithuania, and they could be an effective measure for the controlling of future pandemics. Furthermore, they insist that Lithuania relatively successfully managed first COVID wave in spring 2020. In response, I'd like to emphasize that any medicinal intervention should be based on scientific evidence. Before any intervention, we should consider the level of evidence at the evidence-based medicine. So, what was the scientific evidence for COVID passports? They just based on a false claim that vaccination prevents the transmission of COVID. Endpoints of clinical trials neither included effect on transmission nor effect on mortality. Despite conflicting data on COVID transmission, vaccinated people got COVID passports automatically. I go back to the paper published by governmental scientists. After reading it, I acknowledged that they have no studies behind. This is just a narrow view based solely on mathematical modeling. Where are COVID passports in evidence-based medicine? Let's have a look on its pyramid. First, I will remind that for marketing authorization, level 1 evidence is required. In case of COVID vaccines, we had randomized controlled clinical studies, but the endpoints included prevention of symptomatic infection and prevention of severe infection. So, regarding transmission, we are at lowest level. We have just contradictory expert opinions and some ideas, speculation. Of course, a study of effects of vaccine on transmission of infection is highly complicated, but still we can make a broader view. We can also consider the randomized control trials, the mortality in neighboring countries, the national immunity and spread of infection, and the public health dimension. First of all, let's have a look if Lithuania really relatively successfully managed first COVID wave in spring 2020, and also how did the epidemiological situation change with COVID passports. Can you see the first outbreak of COVID in Lithuania? I will help. It's here. Governmental experts say that their statement on successful management of the first wave in Lithuania is based on low prevalence of COVID antibodies and on utilization of hospital sector. What happened in spring 2020? Let's have a look on SIR, so susceptible, infected, recovered model, based on the fact that susceptible persons become infected, then recover and become resistant to the infection. So, persons transit from susceptible compartment to infected and then recovered or resistant. First, Sweden. They did not apply lockdown, and therefore quite a lot of people transited to the recovered or resistant compartment. Lithuania applied the quite strict lockdown on Chinese manner, so seroprevalence was very low and occupation of hospital sector was also very low. They just flattened the curve. However, the successful management of the COVID outbreak in spring 2020 just postponed the morbidity and mortality to the terrible winter of 2020-2021. So, this is a position of governmental expert regarding spring of 2020. However, we consider that this management was unscientific and it had terrible consequences. On our understanding, a successful management of any pandemics implies minimal excess morbidity and mortality with as low as possible long-term consequences to public health. Postponing the problem is not the same as solving it. Next, randomized controlled clinical trials. I have already mentioned the endpoints of randomized controlled clinical trials of COVID vaccines. Let me briefly explain how the efficacy of vaccines was calculated in randomized clinical trials. Let's say we have 1,000 persons in vaccine group and 1,000 in placebo group. And we got 10 COVID cases in placebo group with 1 COVID case in vaccine group. Therefore, our intervention vaccine protected 9 persons from 10 which would otherwise be infected. Therefore, the relative risk reduction is 90%. Absolute risk reduction is 0.9% because it is calculated from whole study population. We protected 9 of 1,000. It should also be noted that guideline on the summary of product characteristics requires both relative risk reduction and absolute risk reduction to be mentioned. However, during COVID crisis, this requirement was neglected and only relative risk reduction for short term was presented. Unfortunately, the mortality did not serve as endpoint of randomized control trials of COVID vaccines. These trials neither were adequately powered nor had an adequate duration of the blind phase. However, Danish scientists made an ad hoc analysis of all randomized controlled clinical studies of COVID vaccines involving more than 1,000 clinical trial subjects. The differences in mortality were not statistically significant. However, for mRNA vaccines, the number of deaths was higher in vaccine groups than in placebo groups. Especially high was the increase in cardiovascular mortality. But still, it did not reach a level of statistical significance. Meanwhile, the number of deaths in the groups of adenovirus vector vaccines was lower in comparison with placebo groups. This is overall mortality during randomized control trials of vector vaccines, and this is the cardiovascular mortality. Now, let's compare the excess mortality in Lithuania versus other countries during the application of COVID passports. So we have excess mortality in neighboring countries, so EU countries of the Baltic region. Countries with COVID passports are shown in red, countries without them in green. This diagram shows that on average, countries with COVID passports had twice higher excess mortality in comparison with countries without COVID passports. Calculations are made on the basis of 1 million of population. And you remember that on basis of mathematical modeling, governmental scientists speculate that COVID passports prevented hundreds of deaths in Lithuania, despite the highest excess mortality in the region. Maybe they are kidding. This is the data source, our vote in data. We had a look on the excess deaths at the introduction of COVID passports, then at their revocation, and then made the calculations. Meanwhile, the Economist reports that excess mortality in Lithuania during COVID period is highest in the world. Next, a fresh publication from the British medical journal Public Health. The total number of excess deaths in 47 countries of Western world from the beginning of 2020 till the end of 2022. So they took all countries from where the data were available. And their calculations demonstrated that the excess mortality in 2020 was more than 1 million. 2020 was the year of lockdowns. Next year, 2021, with lockdowns, vaccines, and COVID passports, mortality thus even higher. And still in 2022, excess mortality persisted. Next, natural immunity, which was neglected during COVID period, and spread of infection. Now I think that I should briefly remind immunity. So immunity is innate and adaptive. Adaptive is active and passive. Active immunity may be natural, so after infection, or artificial, after vaccination. In the beginning of pandemics, population is here, 100% is susceptible. Then they gradually get infected and transit to the compartment of recovered or resistant. However, the issue of immunity is much simpler in case of COVID passports. They just scan QR code and recognize if immunity exists or not. And we already know that the data on the effects of vaccines on COVID transmission is conflicting. What came after the randomized control trials? It is especially important to look at this in the absence of long-term properly controlled trials with contradictory data, including waning immunity, viral mutations, etc. And Health Security Agency of United Kingdom regularly published an adjusted rate of COVID infection, hospitalization, and death in vaccinated and unvaccinated populations. Let's have a look on rates of COVID infection. So, the number of COVID cases in vaccinated people was lower several months after vaccination, but later turned out to be higher in all age groups starting from 18 years. It was not simply higher, it was higher from 3 to 5 times. It is some kind of cross-sectional case control study. Honestly, I cannot understand how the governmental scientists can tell that the effect of COVID passports was delayed. These passports were applied from the day of application. So, people who did not possess these passports were not able to engage in most of activities. No shopping malls, no working, no studying, and the effect is delayed. They say that 1,000 of infection deaths daily is psychological threshold for changing behavior. But how can the COVID passports be involved in changing this behavior? Well, Delta and Omicron waves in Lithuania. Here we got Delta wave and here Omicron wave. Here we have application of COVID passports and here their revocation. So after application of COVID passports, number of COVID cases continues to rise several weeks, little bit less than 2 months. Later it falls down and then it rises once again with Omicron wave. And governmental scientists say that this is delayed effect of COVID passports. This is because of inertia of behavior. The governmental experts say that the COVID passports stopped the Delta wave. Let's have a look on neighboring countries. Poland, without COVID passports. This is Delta wave. This is Omicron wave. And here it is stopping of Delta wave. What factor did stop it in the absence of the COVID passports? This is the question. Then Sweden and Norway. With Sweden and Norway, here, Sweden, in Greece, in green, there is no Delta wave at all. Norway also had no Delta wave. What can be the reason? Maybe it was because Sweden has no lockdowns at all, and Norway, in the contrary to harsh lockdown in Lithuania, had also no lockdown in the winter of 2020-2021. Next slide about stopping Delta wave with COVID passports. Lithuania in red, Poland in green. Delta and Omicron waves. They follow quite comparable pattern. Lithuania with COVID passports, Poland without. How can governmental scientists postulate that COVID passports stopped Delta wave in Lithuania? I cannot understand. And finally, the epidemiological situation in Lithuania at introduction and revocation of COVID passports. So, number of COVID patients in hospital per million of people at revocation was 1.5 times higher than at introduction. Number of daily COVID deaths was almost twice higher at revocation. And finally, number of confirmed new cases at revocation was 13 times higher. So, during the application of COVID passports, the epidemiological situation dramatically deteriorated, and after the revocation, it started to improve. Of course, I will never say that it improved because of revocation of COVID passports. On the contrary, to governmental scientists who say that it improved because of introduction of COVID passports. Finally, some remarks regarding public health. Exponential spread of infection is a mechanical process. People in a society observe, communicate, learn, and take precautions without any order, on the contrary to the animal herd. COVID passports do not consider that, dehumanizing people to the point that we are only pawns in the puzzle. Ethical consideration. I consider that it is not ethical if somebody is involved in the formation of governmental policy and then writes a scientific paper advocating this policy without disclosing his participation at governmental advisory board. And conclusions on these COVID passports, which might have caused thousands of deaths. So, during the period of COVID passports, Lithuania had highest excess mortality than any neighboring country without them. The epidemiological situation in Lithuania deteriorated during the time of application of COVID passports. The claim that COVID passports prevented hundreds of deaths has no scientific evidence. There is no scientific data to prove that COVID passports could be an effective measure for controlling future pandemics. So, thank you for attention, and any questions?